So basically, the doctor will have a full consultation with the patient on the iPad. The nurse is there on site. She would, sort of use the device, and the device is AI enabled. So when she puts it in the right location, she hears a beep. It's actually listening to the heart right now. Even the GP at the back end, they listen to the heart sounds and they think, oh, there is a murmur there. I'm not sure, is that a benign murmur or is it something that requires a cardiologist to intervene? They just forward that file to a cardiologist, and the cardiologist says, yeah, that's not a good murmur, maybe this patient requires an echo, or no, that's fine, that's just a regular sound, it's okay. If they listen to the chest and they hear something funny, they actually have a baseline. So as they continue to monitor the patient, they have the file of the first breath sound, and then how has that breath sound evolved into the future. There is full capability to do the sample collection and do everything remotely. So suddenly this technology allowed access to healthcare in a remote location, in a labor camp, in an oil rig somewhere in the sea, or in a palace where VIP, normally doctors are not allowed to go. But with simple technology, you can actually now teleport that doctor there and actually benefit from their expertise in a very timely manner, in a lower cost manner, in a very sort of convenient manner. And this is actually the first solution of its kind in the region to go live. So we have actually 3 smart clinics operating in Dubai, and we have the Smart Doc Team mobile as well, so people can order that through, show that. So that's the end-to-end digital journey. So you can just order it through the app, video consultation takes place, and then if the smart doc visit is needed, that is activated, or if a medication is required, the medication can be delivered to you. So you could be sitting in your office and between meetings, and you can have a complete healthcare transaction with medication delivered to you without actually leaving your office, with just taking 5 minutes in a quiet room and getting examined. So healthcare comes to you. The cost of that healthcare is lower, the value and the convenience is much higher. And for us, this was a technology that we thought was a complete game changer. And we know those transactions, maybe 20% of cases you will need to see a physical doctor. Maybe this time the doctor needs to examine your abdomen, and that cannot be done through the technology. But it's only in 20% of cases that you need to convert this into a full-fledged clinical visit. 80% of times, you're basically solving the problem completely, and you're managing that patient remotely at a lower cost in a more convenient way. That's why we felt this was such a powerful technology to bring to the health industry in the region. And for us, this has been a true winner and a key differentiator for us in comparison with the main competitors sort of in the market. So this is the first case study that I wanted to sort of shed the light on. The second one, which is equally important, I believe, is the chronic disease management solution. The biggest burden on outpatients, as you know, in all of your claims is your diabetics, your hypertensives, all of your chronic disease conditions. How can we use technology, again, to lower the cost of chronic disease? And I think what we try to do there is to align our objectives with the payer community, with the needs of the patient. Because unfortunately, even from my regulator time, I see that always the relationship between payers and providers are pull and push relationship. You are abusive, you overutilize, and providers are saying, you are cutting my payments, you're not paying me enough. So there is always that cat and mouse relationship, unfortunately, which really should not be the case if we are able to align the objectives of the payer and the provider around doing what's right for the patient. And even that may sound a little bit hypothetical. In reality, that works, because we suddenly start to feel that we are a one team and we have a single objective. And our objective as a team is always to make sure that the payer is paying the least amount of money for the patient to get the highest quality of care. And if you change your alignment, and if you realign with that objective, suddenly we become friends and we have a unified target. And we prove to payers that we're actually able to save them money, yet increase the quality of healthcare. So that is a very good example of how we've done that. So we've created a digital chronic disease management solution that in the back end processes everything that happens to the patient. So when a patient is enrolled in a chronic disease management program, an initial virtual meet and greet is set up with a physician that basically speaks the same language that is most relevant from a specialty point of view. In that meet and greet session, the doctor takes the full history and they basically create a management plan for that patient. That management plan is then tracked digitally, so the frequency of blood sample collections, the frequency of doctor visits. As much as possible, these visits and those transactions should be remote or digital. Again, as the more the patient is away from the physical environment, the less is the cost. So we always maintain that low touch in line with the best practice clinical guidelines. All of the communication takes place in the back end through omni-channel communication, so through the app, through WhatsApp, through email, through SMS, whatever is more convenient to the patient. All of the services happen as much as possible digitally or remotely with medication delivered to the patient. And what did we do at the end? We use that technology to actually analyze how did we impact the quality of life of those patients? How much did we save you? So we go back to the payer or the payer representative or the broker with a report saying, okay, with this group you had 50 diabetics, 20 of them were not controlled, all started on the program. Those 20 that were not controlled were costing you this much per year. Now out of those 20, 10 became controlled and that dropped your cost by this much, but improved their quality of life outcomes by this much, reduces the chance of this guy getting a heart attack in the next 5 years from 30% down to 15%. Simple clinical outcome improvement as well as financial saving using a technology that manages the chronic disease management program that previously was being managed manually. So for us, these two technologies and these two case studies have been a game changer where we've been able to impact people's life, improve the quality of life and reduce cost on the providers. And we've put all of these solutions together in what we call a 360 care program basically. So I'm not going to market, but that's basically sort of a viable option that is available. And we use all of these to create a fully customized solution for employers that benefit from the seamless transition between the physical and the digital environment. So wherever digital is possible through telehealth, through all of those smart solutions, we use the digital, low cost, low touch. Wherever physical is needed, we use physical. And the whole seamless integration between the physical and the digital create that healthcare ecosystem that we're proud to present today, basically. So these are the two case studies. So I won't say more. I think let's open the space for Aftab and for sort of questions on that.
Hello. So with this presentation, I believe I don't have to talk much on digitalization and your belief as a regulator, ex-regulator, and then coming in the play directly on the health side of the operations, which the problem which you have seen. And probably I should now, I'm trying to, take it as such, like when I heard like people, the coders, they will get 10-year visa. So there was some scarcity. That's what I think of, because I was thinking of like, why these coders they are looking for here in UAE. It means, for them 10-year visa. So now I understand.
Coders are such a valuable resource. If you look at the UK, for example, how many medical schools are there in the UK? There are only 2 coding schools in the whole of the UK, 2 universities that actually graduate coders. And obviously, as you move much more towards digitally enabled healthcare, coding and standardization of healthcare is an absolute essential. Coders today are a very valuable resource.
That's right. So there is a uniformity, now you said on the coding, irrespective of all the service providers, they have to use the same, which is coming from the regulator. Yeah. Okay. But this regulator, if we talk about again, is you have HAD, you have DHA. So is there an alignment which both of them, or even if we talk about the other Emirates, Northern Emirates, are they going to use the same coding?
So coding standards between Abu Dhabi and Dubai were very similar. So Dubai was using ICD-10 CM, Abu Dhabi was using ICD-9, and then I think they moved to ICD-11. So the ICDs are very interchangeable. There is very good mapping between the ICDs. So as long as you're using an international place, then that's fine because you're easily able to map one to the other. And the Northern Emirates, I believe, are moving in the same directions as well. So the decoding standards are going to be aligned with Dubai and Abu Dhabi.
Okay. The other question is now, since you are wearing different hat and you have seen the other side as a regulator, now you are on the commercial side. No matter you are doing a noble job and coming from the noble, medical profession as well. Now, most of the time what happens, I take in consideration back home in India for me. The companies, the international companies who were not in that space, health space, and they saw that either there's a big gap commercially or also to serve the market, and they came. So now there are two things or two types of player in the market. And just to give, because my ex-employer back was Tata. I started my career with them, with Tata. Tata, they had always a health funding scheme for the poorest of the poor, which you say, below the poverty line for them. And they have built hospitals in remote where hardly they were just a token of appreciation. You can pay or you go, if you can. There were cancer hospitals, which are still being served, This is, again, could be a political question here in this part of the world, I'm using it, but government initiative, when we landed here, 30 years back I'm talking about, I used to walk in, the Sheikh Rashid Hospital or Dubai Hospital or anywhere, and we used to get the free consultation and even the medicine. Even our parents and visitors who were here, gradually we saw that is declining because of the cover, the insurance, and everything was mandatory, which came still. Now the question which I'm thinking of after all this, are you thinking of bringing private-public partnership in this particular scheme? Or just you are talking on behalf of Al-Futtaim, everywhere spreading their wing and spreading their arm, whether in the region or in UAE?
Well, I think maybe going back to the first part of the question, any healthcare system requires a sustainable funding model. And every country tries to define how sustainable is this model for them. So large countries like India, like you said, there is a dependence on the charitable component, on the taxing component. So every country has to design the solution that works for that country. And we've designed the mandatory health insurance system for Dubai, obviously, before tax was there. And we felt at the time that it was the responsibility of the employer to actually fund that scheme. However, we also recognized that it was very, very important to have sustainable, affordable funding options for those employers. And when we came up with the essential benefits package, we actually modeled the cost impact on an employer. So if you were a small grocery in Dubai and you had 3 or 4 employees, what would be the cost of insuring those 3 or 4 employees as a percentage of the annual salaries that you pay? And we modeled the basic benefit package to be in the line of 1.5% of your annual salaries. So if you were paying monthly, 10,000 dirham salaries, all what you add is another 150 dirham that goes towards your premiums that covers the insurance of those basic employees. So the basic benefit package was a protection package that made sure that people are protected from losing their savings, losing the money they spend on food, losing the money they spend on their clothes, the money that they send to their families, and spending that on their healthcare. So the basic benefit package, even though an outpatient, it had a 20% copay. So when you go and see the doctor and it's 50 dirham transaction, you will pay a 12 dirham copay, which is not very large amount, but for a lot of people it is. However, when you go to the hospital and you require a 50,000 dirham surgery, that protection kicks in and you don't pay more than 500 dirhams of copay. So that basic benefit package was designed to protect people from damages related to needing healthcare and fulfill their basic healthcare needs